Our next panelist is Dr. Kate Hendricks-Thomas. She is an assistant professor of health promotion at Charleston Southern University, a speaker and the co-founder of Just Roll With It Wellness. Dr. Hendricks-Thomas is also a U.S. Marine Corps veteran and helps businesses and military veterans improve their holistic health and quality of life. She will present on the physical and mental health concerns of women in the military or building a resilient force.
Thank you so much for having me today. I want to talk a little bit about something those of you who have command or have held command in the past probably speak about frequently, and that's the question of mental fitness and mental health as a readiness issue. Interestingly, I want to go over the issue background, talk about how it relates to service women. I'll share some pieces of some relevant studies with you, but I'm a public health professional and I'm not interested in talking about problem scope and prevalence without solution sets, so that's where we'll conclude today. Again, the issues of mental health, I'm going to speak about them a little bit interchangeably, specifically because stress injury, depression, anxiety conditions are all predictors of suicide, which has become a problem for our force increasingly. That wasn't the case 15 years ago. The military had much lower rates than the general population. But interestingly, the conditions often co-occur, and because the symptoms are different, highly individualized, they're often misdiagnosed. We have some serious cultural stigma issues. Those of you in the audience are probably well aware of the treatment recalcitrance of our military population. I like to say you can keep your couch. And that's how a lot of our service members who are suffering with conditions feel. We have misunderstood the problem for a long time. We've talked about it as being combat stress, combat stress, combat stress, when really service separation is a much more likely predictor, or feelings of alienation and low levels of social support. So I've worked with a team of researchers to explore that red range on the slide for the last couple of years. We're trying to look for variables, both demographic and behavioral, to predict whether somebody will have a mental health condition, understanding that mental health conditions become readiness issues at the unit level. And much of the secondary analyses that we've run have had really large sample sizes, and I'll share pieces of those with you. Again, because we're interested in upstreaming, we're really looking for these data to inform our prevention efforts. So again, it's not just about problem scope and prevalence and who's likely to have these issues, but it's about how do we target intervention programming and what should the content of said programming look like. So I'm going to share some results with you today that use data from the Centers for Disease Control, and this particular set of regression analyses had a large sample size, over 54,000 respondents, and we had over 4,000 women that we used in our breakouts. So anytime we're talking about a large cross-sectional survey, I know a lot of you are aware this is a pinpoint in time, so these data are correlational, not black and white causation. But it was interesting because we were looking specifically for who has a diagnosis of depression, stress injury, some kind of mental health problem, and then who's walking around demonstrating or displaying symptoms of an undiagnosed condition. Because if we can predict that, we can really target our programming. We can figure out where some of our issues are. And the data, doing a literature review, we expected to see somewhere around 15% with a diagnosis, and that is what we saw. But interestingly, almost 8% of our sample were self-reporting symptoms that indicate an undiagnosed condition. So those undiagnosed conditions can become a problem. We did a breakout of our female service members, and we found that you're more likely to have these issues with the female service members. So I'll direct your attention to the odds ratio, the second odds ratio. There are women were more than twice as likely to have an existing diagnosis. They were also more than 1.7 times more likely to be displaying symptoms of an undiagnosed condition. We also looked at the variable of service era, because this was not just active duty members, this was a veteran population. And interestingly, you'll notice that the people most likely to have a diagnosis are your Gulf War era, and you're much more likely to be displaying undiagnosed symptoms if you're from my generation, that post 9/11 OIF, OEF era. So the question for any public health professional at this point is, okay, there's an issue, but why? Why is there an issue? And I know Colonel Herring is going to go into detail on this, but for female service members specifically, there are issues with social support and unit cohesion that make it much more likely that they're going to have poor mental health outcomes. And for all service members, for men and women, specifically, you've got practical, we talk about practical and statistical significance. So statistical significance matters on a chart. Practical significance matters to the CO and matters at the unit level. And we have such significance when we break out the variable by people who report not having a lot of social support in their life. So if you have a lower level of social support, you're much more likely to have these issues. And quite frankly, the system as it's currently structured has not been ideal for military service women. It has not been ideally cohesive and supportive for service women. One of my favorite researchers is Dr. Brown out of the University of Houston, and she said, stories are data with a soul. And there has been a lot of really important qualitative research that have collected these stories from service women, and they tell us that we've got some institutional issues, we've got some leadership issues, we've got some trauma experience issues that are creating mental health issues for our service members. So in addition to structural and leadership change, we have to be talking about targeting our behavioral health interventions. And this is where, when we start talking about mental fitness training in our force, I get really engaged and excited and interested, because we're doing a terrible job right now. We can be doing this better. Resilient traits are those traits that allow you to take a punch in the teeth, allow you to weather stress, and those can be trained, cultivated, and tested for. And they're extremely specific, and they involve a lot of agentic downregulation of an individual's nervous system. Programming to teach people to do this sort of thing is really best done in a peer-led environment. It needs to be kind of tailored to subpopulations, and we can do all of that. We know how to. But I think what's key in the military population as we move forward and we see integration moving forward, it's key to understand that you have to have a performance metric attached to such things. It cannot be, more PowerPoint-heavy annual training that people sit in an auditorium and do. Mental fitness training can be assessed in the same scalable way that we assess physical fitness training. And I believe that is an important component for our future as behavioral health professionals working with the military population. So I know Colonel Herring is going to go into more detail on this predictive variables. Thank you very much.